Hey everyone, I am Jean Rowe, the Associate Director of Support Services for the Young Survival Coalition. And for those of you who may not know, YSC is the premier organization focused on the unique needs of young women who are diagnosed with breast cancer. YSC offers resources, connection, and education so women feel supported and empowered. And we're proud to bring you this interview today in partnership with VisionRT. VisionRT develops marketing, leading technology for surface-guided radiation therapy, also known as SGRT. Because accuracy is vital during radiation therapy, radiation therapists take great care to ensure that patients are in the right position for treatment, to ensure that only the target area receives radiation and that healthy tissue is spared. The technology Align-RT detects motion during radiation therapy, and if the patient moves outside an acceptable position, even by a millimeter, Align-RT automatically pauses the radiation and begins again at the right time. VisionRT systems are in 37 of the top 50 U.S. News best hospitals for cancer. Today's conversation will be focused on radiation therapy, how to prepare for treatment, side effects and new methods for alleviating short and long-term side effects like the use of SGRT. And support for today's interview is provided by VisionRT, and we thank them for their generous support. I know you all are going to have a lot of questions about deciding to get radiation therapy or people who have already completed it. And we're excited to welcome our experts here today, Dr. Nancy Wiggers and Ellen Herron. Dr. Wiggers received her bachelor's degree at the Georgia Institute of Technology before attending medical school at the Medical College of Georgia, where she also completed her residency in radiation oncology. A board-certified radiation oncologist since 1995 and expert in the field, Dr. Wiggers co-wrote the textbook Portal Design in Radiation Therapy and is the chairman of the Northside Hospital Cancer Institute Radiation Oncology Program. Dr. Wiggers has a special interest in breast cancer, working with her referring surgeons and medical oncologists to develop a treatment plan to minimize heart, lung, and soft tissue toxicity. Ellen Heron attended Georgia Southern University and Armstrong Atlantic State University in Savannah, Georgia. In 2008, she received a bachelor's degree in radiologic science, graduating cum laude. She worked at Duke University Medical Center in Durham, North Carolina, and the Kaiserling Cancer Center in Beaufort, South Carolina. In 2012, she joined Northside Hospital's team, where she now serves as senior therapist at Northside Hospital Cancer Institute's Alpharetta campus. Ellen is a panelist for the SGRT Community Forum and an advocate for the use of SGRT on all patients. So thank you both for joining us today on this important topic. So let's kick off our questions. So what exactly is radiation therapy and who receives it?
So I'm a radiation oncologist, Ellen's a radiation therapist, and we deliver radiation therapy. It can be delivered in different ways. Primarily today we're going to be talking about external beam radiation, where we use photons and high energies to deliver radiation to the body. You can also deliver radiation therapy with actual radioactive sources that are placed inside the tumor, inside the body.
Is that like radioactive beads?
Yes,
okay.
Like seeds. A lot of people hear of prostate cancer seeds.
Mm-hmm.
And so internal radiation or brachytherapy is one way to deliver radiation. But I think today we're going to concentrate our efforts on the external beam treatments, where people come Monday through Friday to get an area treated with the radiation therapy.
What should a patient expect from pre-treatment or simulation appointments?
Yeah, so after a patient consents to have radiation with their doctor, they come to us for a CT scan. And from that CT scan, we try to get the patient as comfortable as possible with all their body parts out of the area where we're treating. And then from that CT scan, the doctor, endosimetrist, plans their actual treatments using their internal anatomy. And for our center, we actually have Align-RT, so we do not place marks on the patient. If you don't have that software, then typically you would put marks on the patient, or some places use permanent tattoos. So one of the bonuses of Align RT is patients don't have the anxiety to worry about keeping their marks or constant reminders of what they're going through.
Why is simulation so important?
Yeah, so these appointments are important, number one, because the patient needs to be comfortable in how they're laying, because our whole goal for treatment is to replicate and reproduce that position done at CT. And typically you would have 3 marks on the patient, and those are reference marks we use for treatment to line them up. If you have Align RT, it actually has thousands of little marks that it watches on the patient, so you get kind of a better representation of their body contour to line them up for treatment. So comfort and precision is super important for that appointment.
Yeah, and I want to say across the country, most simulations are now done with a CAT scan. We also used to do it with a fluoroscope, and that just didn't give us the 3-dimensional picture that we can get today. And so on the CAT scan, the physician will take that scan, and depending on the area we're treating, outline a target volume, and that's what we want to treat, and then we'll outline the normal structures that we want to keep out of the field. And the image guidance that Ellen's talking about too, or we'll be talking about, will also help keep that body in the exact same position that you're in on the CAT scan day.
So a patient goes through simulation and then they come for their appointment. So what can they expect, particularly on that first day and sort of going forward? Because it's the same thing every day.
Same thing, usually the same time too. The first day for treatment takes just a little bit longer. In our center, we take x-rays, do extra checks to verify we're in that correct position before starting treatment. So we usually allow 30 minutes for that. Typically on a typical day for a normal breast patient, they're in a 10-minute time slot. So they come into the room, check their picture and birth date, and then we set them up, and usually at their CT we make an immobilization device. It's kind of like a beanbag, kind of gets them close to the same position. It's like a starting point for us every day. So they get in their beanbag, and then from there we use Align RT to fine tune their position, and if you had marks you would use marks then to fine tune it. We do a couple checks on our end, and then on a normal day we go straight into treatment.
And typically external beam radiation is a Monday through Friday treatment. They're in and out in 15 minutes. No nausea, vomiting, they're able to drive themselves. They feel good both before and after treatment. And it can range from just a couple treatments. We have something fancy called stereotactic radiation, where we're very specific and give a high dose, so it's just a couple treatments, to up to 7 weeks of treatment. Right. So it depends on the treatment area. But the goal is to have the exact same area treated, and throughout the whole treatment, through the whole course of treatment. Right. So Ellen's watching the patient, not only setting them up the first day, but watching them throughout treatment every day to make sure the same area is being radiated.
Okay. So you mentioned sort of the focused, really short term, and then a 7-week period. What can a patient expect for short or long-term side effects of radiation?
So side effects, we have both short-term side effects that are acute, that happen during the radiation treatment, and then we have long-term side effects that can happen months after the radiation. So during the radiation, both of them depend on the area that we're treating. So someone that we're treating the breast, it's only the skin and soft tissue that are in the treatment field. Whereas if we're treating the pelvic area, they can get diarrhea, burning with urination, because it depends on the organs that are being radiated. So the radiation oncologist will go over both the short-term treatments, and then long-term, you think of radiation as drawing in the tissues or maybe a little scarring, and that can develop in the future. So they also go over, what can possibly happen from the radiation.
Okay. What do you, as a provider, go over, like how to alleviate some of these side effects or how to address them?
So we have medicines and creams that we use depending on what the short-term side effect is. For instance, for breast, we give everybody some lists of creams that they can use, and we like to start them right at the beginning of treatment. One of the side effects is the skin in the treatment area can get red. And so we go over that, and then we talk about long-term that the breast tissue itself can get tight and ways to work with that, like massaging the area. Again, each area has its side effects depending on what's in the radiation field, and then the physician will go over medicines or creams or therapies that can help alleviate those side effects.
Okay. And what is DIVH?
I'll let you take that one.
Yeah, so DIVH stands for Deep Inspiration Breath Hold. And it's for left breast patients primarily is what we use it for, to get their heart out of the treatment field.
Oh.
So, and this is a capability we have with AlignRT. There are other systems out there that you can achieve this with too. And I will say I've used both, and AlignRT is a little more user-friendly and easier for the patient. But for a DIVH patient, their setup is the same as a normal breast patient. We take them in the room, set them up, fine-tune them, fine-tune their positioning, and then we ask them to take a breath in. And on the DIVH patient CT day, they're also holding their breath on their CT scan. So what we're trying to do is replicate that same breath. And AlignRT gives us the parameters we need to do that. So we get them in that correct position, and then when they're in the correct position, we deliver their treatment, and then they can breathe. If for some reason they were to let their breath out during treatment, we would simply, actually AlignRT turns the actual beam off, and then when we get them back in that position, we continue.
Okay.
And what's great about it is our old data, we have patients treated years and years ago, and we found that 20 years after radiation to the left heart, we left side where the heart is, we found increased risk of coronary artery disease. So the DIVH is a way to remove that side effect from the treatment. So if this is your ribs and this is your heart sitting way back from the ribs, the beam comes right under the ribs, and that person's fine. They don't need to do breath hold. But if your heart sits right up under the ribs, it's the coronary arteries, which run right down the front, are in the scatter of the treatment beam and can cause coronary artery disease. So by taking a deep breath in, it pulls the heart back and alleviates that as a side effect.
It's genius.
Yeah.
Yeah, it's great because especially when you treat a lot of young people, you don't want to add another long-term side effect to their life. So,
is there anything else you can think of that a patient should ask a provider in terms of choosing radiation or preparing for side effects? Or do you feel we've covered it?
Well, they should definitely ask, and also think about what part of their body is being treated, what other organs might be at that site, and how the physician is designing the radiation field or protecting it with medicine, what they can do to alleviate those side effects.
Yeah, and I would say for me, if I was going through something like this, and since I'm in the field, I kind of know this stuff, but it would be important for me if they had a system where you didn't have to require marks. That'd be super important. Like we used to use stickers that went over the marks, and patients had so much anxiety about losing stickers, like in the summer swimming, sometimes wearing certain shirts, their marks would show. So just to not have that worry would be important for me. And then if you are younger and having your left breast treated, the DIVH capability would be huge too.
And say again what it stands for.
Deep Inspiration Breath Hold.
Okay.
Yeah.
All right. If a patient's already completed radiation treatment, this is kind of a big, broad question. Is there anything else you should know? I mean, if somebody, we've sort of talked about leading up to and going through. Now someone's finished. You've touched on the long-term possible side effects. What are some of the questions kind of after the fact?
So when our patients finish and they come back for their first 6-week follow-up, we go over what we call a survivorship plan. And what do they have to do in the future? Are there certain tests that are going to be ordered? How often do they need to see a doctor? And we kind of write out a regimen for them. So I think it's good to ask your physician, how am I going to be followed up? How often do I need to come see you? And then how to take care of my skin in the future. Do I need to wear sunscreen? Am I okay to work out, how lifting weights, things like that? Like, what is my plan for the future in survivorship? And so that should be a conversation that's taking place. And it's nice to do it at the end, because we might talk about those things during treatment, but it just gets lost and you're overwhelmed with everything else going on.
How does reconstruction play in with radiation in terms of it being complicated, or does it impair radiation in any way?
So, great question. So we treat reconstructed breast all the time. And there are different types of reconstruction. You could have an implant or a tissue expander placed in there. You could also have a tram flap or a latissimus flap, which is your normal tissue, which has been brought up into the treatment area. You can radiate all the above, and it doesn't compromise the radiation treatment, but the radiation can sometimes compromise your cosmetic result. So it's very important from a technical standpoint for the radiation to be delivered in a very even way, and so you don't have what we call hot spots that can irritate or give excess dose to a certain part of the reconstruction. So we try and do a nice treatment plan where everything is very even dose-wise, and then we also go over creams that you can use to help keep the treatment area soft, keep the collagen and elastin going, and sometimes therapy can be helpful in terms of the lymphedema therapy. People not only work with the arm, but they can also massage the breast or chest wall, work on range of motion. This can all help the reconstruction in the end. The problem is the radiation can draw in that tissue and cause fibrosis and scarring, and everybody's different. You have some people that come back in 6 weeks and a year and 2 years, and you can't even tell they had radiation, and then other patients have not their optimum cosmetic result.
Which is, I think, an important distinction, because I do know that in our constituency, there's a lot of conversation about, did you have this happen? And you really can't compare one person to the other.
It's really tough, and you can't say that, oh, you have fair skin and blue eyes, you're going to have more issues. It has a lot more to do with your diameter, and a wide person versus a narrow person, or an A cup, a wide, or a triple E cup. You have to get essentially that same radiation to the center. And so you can imagine on a wider person, they're going to get more buildup on the side. So you could have somebody with red hair, blue eyes, fair skin think, oh, I'm just going to do awful, and they get through and they're barely pink and don't have any issues, and then another person. So it's more your anatomy than your skin type.
All right, you touched on lotions. What about natural treatments like vitamins or essential oils? Any downside to that?
So you should always discuss it with your doctor, because there are some antioxidants that you don't want to use during the radiation treatment. But we encourage people to use things that aren't, as long as they're not going to counteract the radiation, we're fine with that. And we actually encourage some natural, like aloe is a great skincare, emu oil. Our head and neck patients, we'll get them to swallow manuka honey. So these are all natural things that we send them to the grocery store to get. But when we know they work as anti-inflammatories and work with the radiation.
Yeah, I think a lot of people like knowing about those options.
Yeah, and what's out there. So it's good to ask your physician and get a list of things you can use that will help the treatment and decrease your side effects.
Right. Anything else that you want to make sure we touch on before we wrap up today?
Can't think of anything.
I can't think of anything.
Okay. Well, we want to thank you both hugely for being here today, Dr. Nancy Wiggers and Ellen Heron, for their expertise and wisdom, and a big thank you to VisionRT for providing support for this webinar today. And thank you, and have a great day.